This is an 18-year-old Caucasian female who presents to the clinic with concerns about increase in her heart rate for the past couple of weeks. She reports that her heart rate ranges from 120 to 130 at rest and can go up to 150 or higher with physical activity. Her heart rate has stayed consistently high, and there are no specific triggers or alleviating factors. She also reports feeling like she's having palpitations as an accompanying symptom, and that's the only symptom she has. She denies shortness of breath, dizziness, or syncope. She has no significant life-changing events or stresses in her daily life, and this is the first time she's seen a provider about this condition. She has taken no medication. So review of systems are negative, except she endorses recent elevation in her heart rate as discussed in her HPI for the past couple of weeks. She denies dysrhythmias and peripheral edema, and she also endorses a history of heavy and painful periods. Her past medical, surgical, and family history include COVID-19 infection, dysmenorrhea, and problems with environmental allergies. She takes a birth control pill daily to manage her dysmenorrhea, and she also takes Claritin 10 milligrams and uses a Flonase nasal spray to manage her environmental allergy issues. She has a family history of thyroid disease, rheumatoid arthritis, hypolipidemia, heart disease, and hypertension, and she has no surgical history. She identifies as a heterosexual woman, lives with her parents, denies smoking, drinking, and use of illicit drugs, and she's a full-time college student. Physical examination vital signs include blood pressure 120 for 86, heart rate of 124, O2 sats of 98, respirations at 16, temp at 98.1. On physical examination, she has normal S1, S2 heart sounds, no murmurs, gallops, or carotid bruit. Pulses are within normal limits at +2. A cap refills at less than 3 seconds on all extremities. No edema noted in bilateral extremities, and no blockages, swelling or restricted range of motion. Her neck is supple and thyroid is not enlarged. A 12-lead EKG completed shows sinus tachycardia with a heart rate of 124 and CBC, CMP, TSH, lipid levels, and troponin all drawn. So based on subjective and objective data, differential diagnoses include chronic iron deficiency anemia based on her heavy periods, hypothyroidism based on her family history of thyroid disorders, and anxiety disorder, which all have classic symptoms of tachycardia. A review of her labs indicate no abnormality with her troponin levels or any discrepancy with any of her CBC and CMP lab levels, except for the high lipid levels. A review of her EKG also notes sinus tachycardia with a heart rate of 124, rules out any dangerous acute cardiac problems such as an MI, which has a mortality rate of 11.7 1 year post-MI. So final diagnosis based on subjective and objective data gathered is inappropriate sinus tachycardia. And this is a clinical syndrome that is characterized by a sinus heart rate inexplicably higher than 100 beats per minute at rest that is also associated with symptoms like palpitations, dyspnea, dizziness, and the absence of primary causes of tachycardia. A diagnosis of IST requires the exclusion of other causes of tachycardia, including medications and substances like beta blockers, etc., and certain health conditions, including fever, hypothyroidism, and panic attacks. The plan and treatment for this young lady was we recommended and initiated wearing a 24-hour Holter monitor for 14 days, as IST increases the risk of supraventricular tachycardia. A referral to cardiology was initiated immediately for further evaluation, and the PCP and the cardiac team will plan to coordinate patient care appropriately.